Hi, good morning, everyone. I guess, yeah, for those that don't know me, I'm Paul. I work in the strategy unit as an analyst. Been working there for a number of years, not quite 30 years, Rachel, but a good while anyway. Um, so I've got kind of two aims with this kind of talk this morning. Let me just bring my slides up. So the first really is to kind of a shameless plug or promotion of a piece of work that's about to go live. And the second really is to offer a thank you to you, a thank you to the Huddle community for helping with the development of this project. Can I just check everyone can see my slides? Someone give me a thumbs up. Yep, cool, thank you. So just by way of background, I presented on this topic, I'm going to say back in the autumn, it might have even been last summer, so a while ago. And at that time we had a beta version, a pre-release version of our tool, but we were really conscious that we hadn't tested it or shared it outside of, a relatively small internal team that had been involved in its development from kind of day one. And so I came to that huddle with a request for volunteers to help with testing the tool. Wasn't entirely sure how that would go, how many people would volunteer, but we got a really good response. And I think in the end, we recruited about a dozen people who offered to spend some time playing with the tool and to provide some feedback. And that was really, really useful for us. We got some really helpful feedback. We made some changes, which I think definitely kind of improved the tool. So there were things that we'd missed that were picked up by the people in that group. Just wanted to say kind of thank you to those people that helped. And I'll kind of give you a quick demo of the tool in a bit, but you'll see towards the bottom of the page that we've kind of named those people just to kind of acknowledge their contribution to the project. So that's kind of background. And I'll just kind of briefly go over kind of, I guess, the overarching themes that kind of underpin this piece of work before I give you a quick demo of the tool itself. So kind of thinking about how demographic change, so population aging, will affect demand is kind of it's kind of one of those big questions in healthcare. It's a recurring theme in many of the projects we get involved with. People keep coming back to it, and it is kind of a really fundamental step early on in the process about decisions around scaling and designing health services. And it's also a challenging question. By definition, the future is uncertain. So kind of whatever you do in this area requires a series of judgments and assumptions. But we can't just do nothing. You can't plan and build lots of new hospitals without making some judgments about how population size, population age structure, and indeed population health status might change. So there are kind of three inputs to kind of modeling in this area that I'll quickly cover. So the first two are relatively straightforward. So it's fairly uncontroversial to say that future demand or need for healthcare will be determined by the size and age of the population. Other things being equal, a bigger population or an older population tend to require more healthcare. And these two channels are kind of relatively straightforward. They're kind of fairly neat, tractable concepts. we understand how kind of things like assumptions about life expectancy, fertility and migration impact on our population size and age structure, and we kind of have established methods for modeling those things. But kind of within our work, it's what we kind of wanted to highlight is that that doesn't capture everything. And one important thing it won't capture is changes in population health conditional on age. So what we're talking about there is whether levels of illness are worsening or improving at a given age. So kind of changes in healthy life expectancy. So on average, in the future, is a 70-year-old going to be more or less healthy than a 70-year-old today? And this kind of concept or channel of health status is often overlooked, and it's overlooked, frankly, a lot because it's difficult. It's a kind of relatively abstract, multi-dimensional concept. There are kind of lots of different measures, but it is inherently quite difficult to track over time. We don't really have established methods for incorporating health status in our modelling, and there's kind of much less of a consensus about kind of how people think health status might change over the medium or longer term. So those are kind of the three channels that we're thinking about when we're kind of doing modelling in this area. And so kind of we as analysts or modelers face a number of challenges, and I boiled them down to kind of the three big ones here listed on this slide. So it requires making a judgment about how population health status will evolve, and I've kind of said there isn't kind of a clear consensus on this. So kind of the approach we've taken is to rely on expert opinion, which is kind of something that people often fall back on when we don't kind of have reliable data sources. There's a challenge around, even once we've made those judgments about how we think population health status might change, kind of the technical challenge of incorporating that in a model. People have tried and experimented with different approaches. It often gets quite complicated, but there isn't kind of a set approach that's kind of, I guess, a standard for kind of incorporating it or tackling that in a model. And then there's a question around uncertainty, which I think is a kind of a much bigger general issue whenever kind of you're doing modeling, but it's really heightened here given that the uncertainty around one of those key channels, population health status, is so great. So here a single kind of point estimate really isn't going to be, or it's going to be limited value, I'd say. So you need to think about how you're going to capture that uncertainty and then reflect it in the modeling you do. And kind of these challenges aren't unique to us. When I show you the tool, there's some link outs to kind of other people doing similar work in this area, and you'll see that we're kind of all facing the same challenges. And then just finally, something on kind of the objectives of kind of this piece of work, what we're trying to do. So I know that kind of that first bullet point sounds a bit kind of pompous almost, but kind of what I'm really trying to get across here is that we want to share an approach that is transparent, accessible, kind of well documented, and in some senses generalizable, that people can kind of pick up and use as is, or think about how they might want to build on it, iterate on it, improve on it. But we want to kind of make that widely available. we want to kind of raise awareness around this issue of population health status, which we think is important and not very well understood. And we kind of benefit from kind of more research and more work about how we kind of approach this, because, particularly over the longer term, it is important. And then just kind of, engage with as wide an audience as possible around some of these questions, and kind of during this work, we've kind of had some really useful conversations with people at the Health Foundation, with Richard Wood's team down in Bristol, about kind of different approaches, and we kind of want to build on that and kind of keep that debate and discussion and engagement going. And yeah, just kind of get kind of this more general point about how we incorporate uncertainty into our modelling, and do better at kind of communicating that, but also kind of helping people understand what that means for when they kind of come to making decisions based on something that is inherently uncertain. So I'm going to stop sharing that now if I can. And share a different screen. Okay, so hopefully you can all see this now. So this is I'll put the link in the chat, and people should just be able to browse to this page. We'll see whether it breaks if everyone kind of suddenly visits at the same time. So I'll just kind of give you a quick overview of what the tool that I've been talking about, and that we've been working on, that kind of you guys, the community, have kind of helped us shape. So kind of, in terms of kind of the general format, we've kind of got a single page, and you kind of scroll up and down, and there's some kind of text narrative which kind of explains what you're looking at. And then we've kind of got three interactive visuals. The first of which is this population pyramid, and you can select from the drop down any local authority or ICB within England. So hopefully you can kind of find yours on there. And the pyramid will change to reflect your local area. We've kind of got a play button here, and you can kind of scroll through up until 2043, I think, which is kind of the horizon of the most recent set of subnational population projections. And you can kind of get a sense of how kind of those two channels of population size and population age structure have changed since 2000, and will kind of continue to change in your area going forward. And the ONS also produce a set of variant projections to cover kind of different assumptions about how life expectancy, fertility, and migration might change. You can select one of those variants to kind of look at some of the, or kind of the way that ONS kind of model that uncertainty, which is around producing those variants. So that's kind of your first interactive visual. Then the second one looks at the relationship between age and use of healthcare. So we know for lots of types of healthcare, older people tend to consume more of it, but that relationship is different for different points of delivery. So it's kind of quite different for example, for walk-in arrivals at A&E. And again, you can kind of play around with the 3 main points of delivery for acute hospital care, and you can select your own area. Obviously, kind of once we drill down to more local areas, kind of that looking at real data here, so it's kind of a bit more kind of volatile or spiky than the data for England, but you can kind of click here and smooth out those relationships, so you can kind of get a broad sense of what those relationships look like a bit better. So that's kind of how those kind of 2 channels, population size and age structure, work differently for different types of healthcare. We've got some narrative about how we approached the modelling of changes in population health status, and kind of how we incorporated expert opinion on how that's going to change. Kind of, I won't go into the detail, but kind of very briefly, that's incorporated in a model by using Monte Carlo simulations. So we run the model thousands of times and produce a distribution of results, which is kind of what's shown in this kind of final interactive, where we look at what all that means for how we think levels of demand for different types of healthcare will change in the future. So you can select different model horizons out to 2040. You can select those different points of delivery, and kind of the bars here are kind of showing more probable and less probable outcomes from those Monte Carlo simulations. So the darker areas are kind of the outturn that we think is most likely, but given kind of the uncertainty involved, it could be there's a small chance, I guess, that it could be at one end, kind of where these bars finish. And yes, obviously you can kind of select your own local area to see how that affects things there and how that compares with the national picture. And have a bit of time. Yes, so there's a couple of links out that, if you're interested in kind of this topic, I'd encourage you to kind of follow those. So there's work there on this topic that Richard Wood's team have been involved with, and the Health Foundation have been doing modelling with the University of Liverpool. Kind of both have used different modelling techniques to kind of approach the same question. So I kind of think down the line there's kind of an interesting piece of work that we've kind of talked about doing that would compare the results of those kind of 3 different modelling approaches and try and understand to what extent they differ, and kind of what's kind of the underpinning reasons for kind of any differences that we see. And yes, so down here, those that were kind of involved in the user testing, hopefully you'll see your name listed there, just to kind of acknowledge your contribution and help with developing this tool. So I'll kind of let you explore that in your own time, just to say that we will be kind of putting out some comms around this over the next couple of weeks. So I think we're going to have a piece in kind of one of the trade journals coming out imminently. There'll be something on our website as well, and kind of more generally, if people want to get in touch with me or have questions or want to talk about kind of me coming to present to another forum or talk about it in more detail, then kind of absolutely happy for people to kind of get in touch with me and ask those questions and kind of continue that conversation. So I'll kind of pause there and have a look at your questions. I think I can see some. Thank you.
Thanks, Paul. I mean, so we haven't got time to go through all of the questions here, but you might just want to maybe pick a couple, one or two. Yes, the slides will be shared. I can do that one.
That's an easy one.
Yippee! I'll tell you what, I'll take the first. There's a couple of points there and a couple of questions, but I think there's some.
Oh, okay. You can't see the link in the chat. Yeah. Okay.
So I've shared my screen. All right. So what I'll do after, Paul, is share any unanswered questions or points that people have made on here, because we haven't got time to go through them much.
Yeah, there's a link. So what's something about the code? So there's a link to GitHub at the bottom of the page. You should be able to follow that and see the code.
Okay. So I'll share the link out that you put in the chat that some people can't see after today's session, and any unanswered questions. But there's a nice one there saying, thank you so much, fascinating, the interactive
Did you do that,
population pyramid. Actually, no. How odd. But yes, so I would have, obviously, because it is a thing of beauty. So thank you ever so much for that, Paul. I got lots of sort of quick queries in my own head, which I won't share now, really about sort of how to the key users of this, who's going to get the most benefit from this. But that's an open question for you to not answer. But I love the fact that you've offered to go and share this with lots of other people. So I do hope people take you up on that offer, Paul, because I know it's genuine. There's a lot of time, effort, and sort of so many people have been involved with getting this to where it is today. So it would be great to get it out there and for lots of people to use it as well. Marvellous. Thank you. Thank you ever so much. And I shall now hand over to Andy and Lucy. Hi, both.
Thank you very much, Rachel. And thanks, Paul, for that fascinating stuff. I'll hand over to Lucy in just one short second and let her introduce herself to all of her new colleagues. Okay, so just to give you a brief sense of the running order, I know we're quite pushed for time, but this will be a run through, hopefully a little bit more focused than Forrest Gump possibly, but yeah, kind of describing broadly what we set out to do and why and how, really. Talking specifically with a use case of Risk Strat, one of our toy models, which will be published, and all the kind of some of the underlying theory behind that. Obviously give you a demonstration, that's kind of the main course, as it were. Link you out to the useful stuff and take questions and suggestions, I think, is our general flavour that we want to close on as well. So yeah, Lucy, if you want to pick up from there.
Yeah, sure. So I think I'm mainly just setting the scene here today, but let me try and put into context what we're trying to do with toy models. So we at the strategy unit, or actually I should introduce myself first. So myself and Andy are both analytics managers in the strategy unit, but this ask came from Professor Mohammed, who is a principal analyst in our research and policy team. And this is part of the NHP project, because it was recognised that as that project was progressing, there were quite a lot of complex models that were being used within NHP across a number of areas, that it would be really helpful to have tools and visual kind of aids to help people understand, complex behaviours in systems. So as part of that, and we've actually created 3 toy models to start off with, but there will hopefully in future be more, and we do want a little bit of feedback from you on things you might want to see in the future as well. But we've started off by making 3 toy models. Andy's going to talk you through the risk stratification one today, but there are also tools on bed pooling and occupancy, and that kind of looks a little bit about variability in what happens if you've got different types of variability in your models there, and also waiting list dynamics. And we've got one also on how bottlenecks kind of can affect systems as well. So really the reason we went for this is so we can communicate better with our stakeholders, and we can disseminate these ideas much quicker, and we can also educate people as we go in small, kind of easy to understand settings, so that when we come to presenting bigger projects or bigger models, the ideas are already cemented there. So we do hope that when we release these models as on the website. That's what we're going to do. There'll be some comms, I'm sure, about that in a few weeks' time, that you'll be able to approach them and play with them and actually see how they're presenting complex ideas, but in a easy and digestible way. So I think that's all I actually wanted to say at the moment. So I'll hand over to Andy, who's actually going to take you through the tool, one of the tools he's built. Thanks, Andy.
Right, thanks, Lucy. Apologies for seeing slightly the left-hand side of my face. I do have to look at the large screen while I'm presenting, otherwise some of the screen grabs and stuff don't look as great on my small screen. So yeah, but picking up from where Lucy's described there in terms of the brief almost that we had, Risk Strat being one of those areas of analytics and commissioning, if you like, population health, which we felt we needed to look at, create some toy case examples and some models. So I've put the link to actually Stephen and Mohammed and Peter Spilsbury's paper. I think Stephen's on the call, not sure about Mohammed, which gives you much more detail around the theory, the principles, the framework, and all of that stuff in more detail. So any spiky technical questions, Stephen's offered to answer those rather than rely on me to blag my way through them. So yeah, a little bit of a recap first on that kind of theoretical conceptual side around risk stratification. And again, apologies to Stephen and the authors for paraphrasing, simplifying things, I guess, for my lay brain to be able to cope with in this sense. But risk strat to me really is about the classification of patients, grouping patients together based on their likelihood of some adverse risk event occurring and for which there might be some action which is available to mitigate or offset some of that risk. Preventive or avoidant activity. Events in a healthcare setting you would typically see as being things like emergency or other kind of admission to a healthcare setting, death ultimately, perhaps disease onset, not adhering to treatment. There's loads of different dimensions of risk you could cover. The factors we routinely see deployed, examined, used within risk stratification algorithms and approaches tend to be, the usual suspects are, again, thinking back to Paul's presentation, actually around demographics, around lifestyle, so people choose to drink, smoke, do physical activity and so on, and how that may change their risk. And obviously their current historic sort of clinical presentation. What are the prevailing clinical factors which might determine someone's likelihood of exacerbating or having some other kind of adverse event? In terms of the options that are there to deploy, develop, design, to analyse, to produce those risk estimates, again, loads of different tools in the toolbox. I'm by no means an expert in many, if any of these actually, but logistic regression is the one, again, probably most commonly used when you have a binary outcome of death or admission or otherwise. So Cox proportional hazards is particularly useful, but there's loads of others within the machine learning neural network family, if you like. Decision tree, support vector machines, extreme gradient boosting, etc., and clustering and classification algorithms again. So k-means, latent profile, density-based stuff. Loads of different approaches you could use to identify and assess the risk of people within a given population. Some examples just for reference, either developed or used across England commonly. So the Framingham Risk Score, which is a 10-year cardiovascular risk. PAR, for those of you who again have been around long enough, patients at risk of readmission, the various versions of that, which was superseded by the combined predictive model, which drew on acute primary care community data, I think, in totality to try and predict again the future risk of patients being able to sort of attending in an emergency. During COVID, the Q-COVID algorithm, I think it was developed by Oxford University around the vulnerability or likelihoods of developing COVID and being at risk of significant adverse events were you to do so. So there's loads of examples within the health system, health and care, the wider system around risk stratification. So hopefully that gives you a sense of the flavour of what risk strat is, what kind of approaches we can use to define that risk. But on the flip side, you as an analyst, you kind of almost think, well, that's job done, right? You've got all your data, you've developed your algorithm, you've deployed it, you've tested it, you've validated it, you've got a risk categorization. You might even have done some nice, profiles to kind of demonstrate the differences between those different risk strata. But you kind of ethically, in the same way that we do with screening programs, once you've identified an at-risk population, actually you should have something which you then have in place, which potentially can, as we say, lower their risk or prevent those adverse events happening. So that's kind of what really we're about today, is about taking the inputs that you derive from a risk strat algorithm, taking those inputs from an intervention facing side point of view, and kind of marrying them together into something which you could then, I suppose, get a high level sense of what the cost implications of doing both of those activities are. On the intervention side as well, just to say again, from a healthcare setting, the ones you might be more familiar with, kind of brief lifestyle interventions, typically done in primary care, I would guess, by GPs and nurses. But you can also do screening and diagnostic programs, and there might be some more sort of invasive or other non-invasive approaches which you could apply to try and interrupt that risk pathway, if you like, that progression of risk. But at the simplest level, I guess an intervention might have something around the unit cost to actually deliver that to patients, and hopefully something on the effectiveness of that in terms of, again, offsetting that risk or mitigating that risk. Particularly the language you may see referred to most frequently is number needed to treat, or NNT for short. So, and again, apologies to Stephen and the authors for kind of butchering their framework. This is my sampling of their extensive and really great paper on risk strat on this, but kind of pulling out what are the key terms which we've rolled into our toy model. So on the risk strat side, you've obviously got your population for scaling. You've got your cost of your adverse event, how much, an admission or a death or whatever the event is would cost to the system or the hospital or the commissioner, depending on your perspective. The positive predictive value of your risk stratification tool, how good is it actually at identifying within a given population those that would then go on to have that adverse event. So the positive is kind of offsetting those negative, false positives, false negatives as well. So kind of outwith of those. And on the intervention side, it's the proportion of your population or the risk population identified within your global universal population that you would like to target for an intervention. The unit cost of that I've already mentioned, on the number needed to treat. So how many people would you need to treat with that intervention to save or reduce those adverse events by 1? And kind of, again, kind of pulling some of that together. So the IMAX, which is the objective function really of finding the maximum value of that unit cost for the intervention, accounting for your given values of, the cost of the adverse events, your PPV and your NNT. So that's kind of marrying it all together really to give you that benchmark, almost that break-even point at which, if you cross with your intervention, you're actually going to end up spending more money than you save. And on the flip side, how much could we save if we actually can drive down the cost of that unit cost? So a very quick illustration of that. I can see time's ticking already. I want to give plenty of time for actually demonstrating the tool. So taking the figures directly from the paper, really just to simplify things. So from a practice of 5,000, for example, your risk tool identifies 100 individuals, or the top 2% in this case, having a high risk of unplanned admissions. Your risk stratification algorithm tool has a positive predictive value of 30.36. So if those in that high risk population correctly identifies 36, who would then go on to have an emergency admission. That's who we want to target. That's prospective. Obviously, we want to do this before that happens. And the NNT for the intervention that we'd chosen based on best evidence at the time, etc., was 18. So for every 18 people treated, 1 emergency admission could be avoided. So looking at our particular population, that means 2 emergency admissions avoided. Let's assume the cost of that is 2,000 per admission. So we've saved 4,000. This is small numbers. It's a toy example, you can tell. So how much must our intervention cost per person, given that we've got to deliver it to all of that risk population to save money? So that's something to quickly crunch in your heads, I guess. I'll save you the pain. I don't actually put the number on there, but it's £40 essentially. So 100 notional 100 population who you have to target with the intervention, and ultimately you're saving 2 avoided events. So onto the demonstration now, which takes all of that and kind of builds all of that and gives you the opportunity to play and interact with all of those different inputs on the risk strat and population side, as well as the intervention side. So hopefully this should work as an overlay to the presentation. If it doesn't, I've got a couple of options. So this link, which will obviously go out with the slides, links you straight off to our Connect server, which is where this is publicly hosted and available. So there's no restrictions on access to this. Again, hopefully If you all try and access at the same time, it should still stand up to quite a bit of server traffic, hopefully. But in the event that it doesn't quite work, you can always refresh the browser or go back and try again. So this is kind of the format which all of our tool models will follow, really. We've got some panels across the top which you can flick between, and the input bars tend to kind of fluctuate depending on what you can control on that particular tab. But by and large, we just kind of walk you through a fairly linear journey, I guess, of the concepts and the different ways that you can, like I say, interact and try and influence and change some of those outputs, given your view on the inputs. And again, it's a really useful tool which you can take into meetings and just quickly on the fly change stuff, try and introduce some of these concepts and show people, you know, like I say, the high level impacts of changing X, Y, and Z, or A, P, and PPV and NNT in this particular case. Just want to give a shout out, actually, should have done this at the outset, actually, to various people, Anya and Sarah in my team, who pretty much built this from scratch in Shiny, but from scratch, actually. Gabriel in the NHP and HSE team, he actually kind of seeded this with a really first sort of basic, he set up the GitHub repo and sort of a basic Shiny app to kind of handle some of the inputs and outputs. So thanks to Gabriel for kind of seeding really the development of this. And obviously Mohammed, Stephen and Peter have contributed editorially, I guess, if you like, to some of the narrative around it. So kind of without further ado, I'll just take you through some of those tabs. Also links in here as well to the other tools which are either currently live or very shortly will be live, and those in development. We'll obviously enhance this and try and cross-pollinate and make sure you can navigate to all of our different tools via this. So there's links in there to the other tools which are currently there. So really looking at the cost savings tab again, which uses the information and data from the paper, which is referenced and again linked out to in here. So it gives you all the inputs that you can change in this left panel, and you can see what happens when you change those. And I'll sort of walk through and change them one by one, so you can kind of see what happens in terms of that high level view of your population. So like I said, the first two really are just about the scaling. So how big is your population? How many people are we likely to be targeting? We'll keep these as standard, but you know, if you, for example, overtype 10,000, you can see some of the text auto changes there. So you can again see the scale of your population is increasing. Your percentage, let's do some crazy adjustments to that. So boost it up to 10%. You probably wouldn't want to focus an intervention on 10% of your population. That's quite large, but you can see it kind of, you can see those figures playing out. We'll reset those just to the standard paper ones, for example. So cost of an adverse event, again, depending on what your adverse event is, it may be higher or lower than this. And if we change this, for example, 3,000, you'll start to see some of these values changing. So the money saved, yes or no. But holding all those other inputs the same, if we do change the cost of our adverse event because of, you know, inflation, time's moved on, we're looking at a different event, you know, you can absolutely do that. At every point, I'll kind of reset these values just so that we can see them. So this is where we start accounting for your risk stratification, the ability of your tool to correctly identify those patients who would have an adverse outcome. Again, that could be higher or lower, depending on the scale of that, the accuracy of that, the data that you fed in. Again, you could use this, I guess, if you have competing risk stratification algorithms. You could deploy them all, test them all, and feed those different values into this to get you a sense of how you would compare those. So again, if we just increase this to, again, something very unrealistic perhaps, but 80% positive predictive value, you can see within your waffle charts here in your population how that would extend the sort of level of population coverage, but also because of our NNT and our intervention costs, actually, you know, you would be able to save more adverse events if you can create a risk algorithm that is better and more sensitive at predicting those outcomes. So just reset those again. So again, coming to your intervention side factor, so your number needed to treat. So again, default values from the paper. If we were to reduce this NNT value, let's make it more effective essentially. So we're seeing we need to intervene on fewer patients to actually avoid more. You can see actually just by doing that, so we found a better intervention, if you like. You can see, although our target population is the same, actually, because we've reduced that NNT, we're actually saving more adverse events. And then on the cost side of that, so if it costs more, for example, to run our intervention, would probably make it less cost effective. You don't actually see the negative values in here. You do later on, but if we do that the other direction, so again, you can see those flipping around and saying, actually, no, because you found a cheaper yet similarly cost-effective intervention, actually you're now running into cost-saving territory. So what you invest in terms of that intervention will, in the longer term, and again, timelines could be very different depending on the interventions and the risk. You could potentially save money by investing in that intervention and sort of population improvement scheme. So that's kind of it. It's fairly simple. There's actually not many inputs to this. The maths isn't actually particularly difficult. All the formulas, we've littered a few into our kind of narrative around this, but there's more obviously in the paper if you need to go and explore those in more detail and understand. So what we do then is to go on to look at the interactions and that kind of max intervention, that Imax variable, if you like, that function really. So again, given all of the default settings, just if you're not sure, reset everything to default. There's that £40 value, which we kind of covered and looked at within the illustration just before I went into the tool. So we've taken off 1 penny, obviously, just to round this down so that you can have that slightly more accurate. And so 40 is the break-even point, so anything below that. But again, as you start to change some of these variables around the cost of your adverse event, you will see that value change. So if our admission value goes up, obviously then the cost that you would need to recoup within your unit cost goes up. As we change the PPV, again, either way, let's go to a less accurate prediction. That actually means your unit cost has to be much cheaper. But if we go the other way and again do that, that kind of gives you more flexibility within your unit cost of your intervention to be able to do more with your at-risk population. Reset those again. Similarly, and you can see in those plots below just how those interact with the Imax, each of those independent variables. You can see where on the curve you are and kind of using the kind of call outs, the tooltips on the plotly objects there. You can kind of pick out those values and see where you are. So again, you can play with the NNT and the unit cost side as well to see what happens with that Imax value. So again, let's make this much less effective as an intervention. You can see your Imax value starts reducing again, so you have to find something which is much cheaper, obviously, to deliver in terms of your intervention. So that's all of the basic theory, that's all the functionality. Like I say, the input bars change dependent on which screen you're on. We've included something around different risk strata. Obviously, as you extend out your risk population, perhaps your risk algorithm has to change as well because you're dealing with a less risky population, and obviously your intervention will also have to change. But we've included this because we want folk to have an understanding of what happens when you extend out your risk strata. So holding all our initial values, for example, we've got our baseline risk strata, again thinking about our very basic example of PPV of 36 and a NNT of that should probably be 2, so that might be a minor bug in our thing. But if you were to extend this out to say your top 10 risk population rather than your top 2%, the PPV of your tool will actually become less effective, so less good, if you like, at picking up those patients who would then go on to have that adverse outcome. So this is just to illustrate that point really, and to say as you extend out your risk target population, that has an impact on the cost effectiveness potentially of your program. You won't get the same bang for the buck, if you like, sorry for that language, but so this kind of plays through those examples and gives you I might have changed stuff in here still, that's why it's not working. Yep, so reset everything. So this, there we go, back to normal. So this is, initial example. If we take the example again, extending our risk population to the top 10%, so our risk prediction tool now is less good at picking up those patients. You can see kind of the impact, on the bottom line. Actually, it's going to cost us money if we extend this out across that 10%. Rather than just focusing on that really high risk population that we have a pretty good grasp of what their outcomes might be. So this is just a way of doing that. Like I say, you can, again, okay, if you want a ridiculous example, if you want to make this completely universal global approach, and actually our Risk Stratification tool now is really, really bad at picking up those patients. You can see the net cost of actually delivering that tool for our notional 5,000 population is greatly reduced and actually going to end up costing us a lot more money than it saves in the long run. So this is just a way of kind of giving the ability to test that sort of relationship and see what happens if you were to extend and change your risk tools. So that's pretty much to time, I think, hopefully. Going back to the thing, there are other few useful links around the risk strat agenda that I've highlighted here. And health economics colleagues produced a really good paper that reviewed lots of those practical applications within the health sector. A risk strat, systematic review of risk stratification tools for health. The links will all follow through, hopefully. They don't necessarily all work within the presentation, they should do, but yeah, you can always click the links or copy and paste the links. Some of the stuff general on methodological and technical aspects of either logistic regression or machine learning approaches for risk strat and broadly epidemiology. So hopefully some useful resources you can read around and explore if you want to find out more about the underlying stuff. So that's pretty much it. Like I say, it was a very quick run through. The link will go out with the slides that Rachel's going to circulate after the session. But yeah, a little bit of time for questions and suggestions, please. I think this is our call out for other ideas for toy models, which you think might be useful in the world that you operate in. You know, if there's sufficient demand or some really good ideas for tools that we could try and design and deploy, I think we'll have the space in the next 6 months to 12 months to develop a few more of these potentially that could then be publicly available for folk to have and play with and test and use in their own kind of settings and scenarios. So yeah, that's pretty much it. I don't know if Rachel, if you've had any questions on the chat, we can collectively address as a team. He says, artfully avoid responsibility for answering them.
Thank you, Andy. Thank you, Lucy. There's a couple of, I think I've shared my screen. There's a, whoops, did I share the right screen? Who knows? Yeah, thank you very much for going through that. It's a simple but very effective, I think, tool, like you say. So I think the part of the development time has been very much to make it just like that, you know, something that people can use. Obviously, thank you to Anya and Sarah, who I saw on the call today. Yeah, no, it's what do we have here? So someone has said that it was really well explained and they would love the links to the tool. Well, that's great because we're going to be sending those out. That's an easy one. So I'll take that one. Great presentation, and somebody really likes the waffle charts. I think they're very effective. So how did you choose that way of presenting? And also squares over people. Was that your choice?
People are all squares. Yes, I mean, some of it was obviously developed in the paper by Stephen, who very artfully kind of used those waffle chart type graphics using people, which, you know, it kind of gives it that real world sense, doesn't it? You know, these are people, these are populations that we're actually targeting. The waffle charts are a really nice way of breaking up, you know, sometimes quite large data sets into bite-sized chunks. So it's a really neat way of showing populations and how different variables affect the size of those populations, which are impacted in various ways. There might be practical ways that we chose squares over people within the tool. And Sarah, I know, who developed that aspect of the tool, might have a really good technical reason as to why we chose squares. Some of it may just be time and practical reasons. But yeah, of course, you can experiment. Similarly to Paul, we are going to open up the GitHub repo. Obviously, the tool's public access, but we will open up the GitHub repo so other people can sort of see how we've constructed and sort of develop the Shiny app and the code to, you know, and quite happy for them to take, use and abuse it as they see fit to do in their local setting.
Excellent, thank you. And so you mentioned in the presentation there's a few other tools that you've already developed and are in development. Now we haven't got time within the 60 seconds that are left to go through all of those, so I might have to have you back, Andy. How do you feel about that?
Always willing and able.
Yeah, you say it now while people are watching, but then I'll come. Andy, should we fix a few dates? Oh, sorry, Rach, bit busy. You will never say that. You never say that. There was a slide I did have for maybe some suggestions that people have, like you say, for where developing a tool like this, where you can sort of, in a sort of kind of discrete, neat way, you can they can explain to people in a simple way what the impact of a certain intervention or whatever might be. So I'm sure there's loads of it. I can't think right now But I'm sure there's lots of ideas that people can have to sort of share with you to make you work very hard over the next 6 months, and that's the main thing, isn't it? So I'm sure you've had lots of fun working on this one. There's a comment from Sarah in the chat. Any work on evaluating virtual wards? Okay, so a lot of chat locally about admission avoidance using virtual wards, and so that might be something that you can look at next. I know we have in the strategy unit done some work on virtual wards, so maybe I'll link in with Sarah afterwards and find out what that is. Okay, well, let's just finish up. I'll just say thank you again to all of you. That's like my slide as promised about asking people what they would like in a toy model. So we can follow that up after today's session, as well as any unanswered questions. So coming up in the next few huddles, we've got the strategy unit again, the NHP demand and capacity model, and haven't actually fixed a date for that, but it's got to be happening soon, I think. Again, we're looking at the strategy unit heart failure, targeted funding program evaluation. So there's an evaluation, Sarah, not the one you're after, but there's an evaluation. Stephen White, who's on the call today, is going to be having a session with us about problem structuring. And we've got a session, and this is the last one I'll talk about. It's humans, AI, and the importance of data literacy. And that's with Dan Isaac from Exeter University. Now, those of you who saw Dan Isaac's data visualization training that we had in part of the MDSN a couple of years ago, you'll know he's really great, and you should definitely make a point of coming to that one. So I will finish up there because we have gone a whole minute over time, which is fine, actually. A minute is fine, isn't it? Thanks again, Andy, Paul, Lucy, everyone else for coming, and I'll very much appreciate it. And we'll see you again in approximately 2 weeks' time. Thank you.